Greetings, everyone. I'm your host for this section. My name is Tao Xu. I work at the South Sports Medicine Center, Southwest Hospital, China. This section will feature for Chinese doctors sharing their experiences and clinical outcomes with a total talus replacement. The topic is beyond tradition, delving into cutting-edge implants, techniques, and outcome in total talus replacement, including various materials options. Due to English is not our native language and time zone differences, we have prepared a recorded video presentation. Please bear with us for any unclear expressions during the presentations. If you have any question, feel free to email us and get in touch. We are eager to engage in discussion to promote the applications and development of the 3D printing talus replacement. Allow me to introduce the first speakers, Dr. Fei Chang. He comes from the second hospital of the Jilin University.
Good morning and good afternoon, ladies and gentlemen. It is my great honor to share the topic related to the total tailor replacement with you today. Total tailor replacement is a new option that has been gradually accepted recently. For some specific situation, this method has a unique and irreplaceable advantage in our clinical practice. At first, let's begin with a case we did long time ago. It is a female patient, 58 years old, suffering from a left ankle pain for about 2 years. Weight-bearing X-ray shows a high density of almost the whole tailor body, but the articular space looks good. We can see from the MRI scan that there are obvious abnormal signal throughout the tailor body, and there is also some collapse located on the tailor head. However, the adjacent articular surface, including the distal articular surface of the tibia, the subtalar articular surface of the calcaneus, and the talar navicular surface of the navicular bone, are relatively intact and have no obvious damage. Similar findings can also be confirmed by CT exam to ensure the entire lesion of the whole talus and an intact joint surface. FAST score of the patient is 7 and the AO FAST score is 35. In this case, what would be the treatment options? Conservative, compression, total ankle replacement, or joint fusion? If thinking about the joint fusion, which joint should be considered? Tibial talar, talar navicular, subtalar, triple, or pretalar fusions? Joint fusion may be an effective treatment option, but it will be sacrifice the joint functions. At the same time, the surgery is very invasive and the risks are high. So it is still not an ideal choice. But if we have total tailor prosthesis, it will be different. We did a surgery for this patient 9 years ago with a 3D printed custom-made total tailor prosthesis. At that time, we were not sure how to choose the size of the prosthesis, so we customized 4 prostheses of different size and put them on the operating table. This is a photo taken during the surgery showing the implanted prosthesis. And this is the X-ray images during the operation. After 7 years follow-up, we can see that the position of the prosthesis is very well, but the osteophyte can be seen in the distal tibia, suggesting that there is still some instability in the ankle joint. However, the patient showed very good joint function. This is the latest follow-up a few days ago, almost 9 years after the surgery. It can also be seen that the joint function is very well. The latest literature just published this year suggests that the long-term results of the total talar prosthesis is better than that of the tibial talar calcaneus orthodesis. Our patient was also very satisfied with the surgery, but when we tried to evaluate the joint function of the patient clinically, we still encountered a lot of confusion, such as how to evaluate the stability of the prosthesis. Are there any biomechanical abnormal? Are there some subtle changes of joint function? There's no suitable method to get evaluate through this traditional scoring system. By thinking this question, we found that there are more methods we could use to evaluate the results of total talar replacement, including stability and other related issues. For example, the three-dimensional dynamic capture system can be used to evaluate the overall movement coordination after operation. Meanwhile, the muscle strength assessment helps us to understand the recovery after surgery. Recently, we are also collaborate with researchers from sports medicine and sports training. By using the technique they have, we could evaluate the joint function quantitatively. Posture control testing is a commonly used indicator for sports testing. Among the testing, a very common parameter is center of pressure, which could be quantifying the extent of body stability. This is the test result of the patient we mentioned above. The green line represents the left side, the side that underwent surgery, and the red line represents the right side, which is unaffected side. The results told us that the left operation side was more stable than the right side in single leg standing. Another useful parameter is the sensory organization test. It is to calculate the proportion of visual, vestibular, and proprioceptive sensation in different environment, and is a highly reliable and useful method for detecting posture control deficits. Pipeline X-ray system is a kind of dynamic detection of bone and joint structures. Through the dynamic detection of two X-rays and then combined with CT images, the dynamic changes of the joint structure can be detected accurately, just as shown in this video. When joint moving, every tiny movement of each bone can be accurately calculated. Therefore, this method is considered to be an effective means to evaluate joint function. Another issue we are concerned about now is prosthetic design. Although the number of total talar replacement is increasing fast, there is still no standard for prosthetic design. Everyone is making different designs based on their own understanding. This manuscript, published in 1997, described a partial talar replacement in which 16 patients received a stainless steel talar body prosthesis with a stem fixation in the native talar neck. This talus was subsequently removed after all of the prosthesis had loosened, and the remaining talus had become necrotic. The research team of Professor Tanaka in Japan also obtained the same results. Their partial prosthesis replacement also had a high failure rate, so they later changed it to total Talar prosthesis. The design of total Talar prosthesis is still mainly depend on customized. So research group are focusing on the shape of the tailor and aiming on the designing universal prosthesis. But so far, the results are unsatisfactory. If the talus on the other side is intact, we can do it through a mirror design. But if it is a bilateral injury, prosthetic design becomes very complicated. The talus is an extremely irregular shape bone. Each of its articular surface has an irregular shape, and there are individual differences, so there are many difficulties in design. There are too many factors we need to consider. What should we do when the joint surface collapses and the shape does not match? When the posterior tuberosity is large or there is an ostrogulum, how should it be designed? If the subtalar joint is also damaged, should the joint be fused? How should the joint surface be treated? And how should the size and the position of the screw be designed? Some people have also proposed a design of metal plus polyethylene, similar to the design of traditional knee prostheses. But there is also a lot of controversy about whether this design makes sense or not. Joint stability is also a hot topic of great concern, because in the case of chronic ankle instability, we require a lot of ligaments. But for total talar prosthesis, there is no ligament at all. What will happen to this unstable structure? The consequences of this are still unclear. Should we design a ligament structure whole or even microporous for biological repair of ligaments? All this issue await further research to clarify. So as a summary, total talar replacement has a relatively good long-term results. There's no serious complications be detected so far. More effective measures are needed for functional evaluation, and the design of prosthesis remains a challenge. Thank you for listening.
Second speaker is Fengqi Zhang. He comes from the 3rd Hospital of Hebei Medical University.
Everybody, good afternoon. My speaker is treatment of the calcified necrosis Talus with 3D printed total Talus replacement. Several source cases. I'm from China, Hebei Medical University 3rd Hospital. My name is Zhang Fengqi. We know Talus articular necrosis of the talus is a children's clinic problem. Managed as the surgical treatment option are relatively limited and highly dependent upon the stage of the disease. In the post-decades, advanced AVN was frequently managed with the authorities and the back struggle algorithms. However, total talus replacement provides a novel treatment option that can maintain ankle joint range of motion while providing adequate pain relief. Total talus replacement are a surgical treatment for the talar Exocular necrosis replaced the entire talus. The patient for total replacement has increased with identification speckle important using the 3D print disease on computer telegraphic scans of the epilateral and then the contralateral talus. This is the talus antimony. They less the blood supply. This is the blood supply. We know TTR are some indications. 1. Degenerative joint disease. 2. Acute ostomal necrosis. 3. Massive bone defect. We select the process start with the measurement of the control talus and the radiography of the ankle. MR, CT scans after a few weeks, we processes was prepared to fit its anatomic structure. We select a anterior approach of the ankle to treat the talus acrothorosis. This with a cord. We use a dorsal closing wedded osteotomy was performed at the talar neck and divide the talus into 3 portions: anterior, medial, and posterior. Then we release the ligament, attach the all section. We use the bone saw, bone chips, remove and mallet or remove the talus. Then we use complete talus remove. 2 important are inserted the articulation or assessed through plantar flexion, dorsal flexion, inversion, and evasion. Then this is our typical cases. The cases 1, the patient was a 33 years old man who was hospitalized due to the traumatic osteomacrosis of the talus. This is the X-ray. We can see in CT scan the talus ectorus. This is the MR. This is the body photo. We can see worker.
往回走。
We use the anterior cut and remove the talus. This remove the talus. Then play a 3D talus. This is the cut.
直区背身内八位翻内旋位时。
我觉得这个卡的很好，它不容易脱。
盲科以后它就不会容易脱位。
This is the X-ray next after the operation. The next day after the operation. This is 6 months after the operation. This is the post-operation operative gait. We can work improve. The next with the next cases, the patient was a 28 years old man who was hospitalized due to the annual born sister of the Talus. We can see at the CT screen. This is the MR. This is X-ray of the operation. 2 weeks of the operation. Three months of the operation. 6 months of the operation. The case 3. The patient was a 68 years old man who has hospitalized due to the traumatic necrosis of the Talus. This is the X-ray. This is the CT screen. We can see the Talus fracture. This MRI. The next day after the operation, X-ray. 6 months of the operation. We can see the X-ray. You're very good. The case 4, the patient was a 42 years old man who was hospitalized due to the osteomosclerosis of the Talus. This X-ray. This is CT screen. This MRI. This the X-ray of the 2 weeks of the operation. 3 months of the operation. This X-ray, 6 months of the operation. The case 5. The patient was a 53 years old man who has hospitalized due to the traumatic osteomocrosis. This is X-ray. This is the CT green. This is the MRI. This is the X-ray of the operation. This CT green of the operation. 2 weeks of the operation. 3 months of the operation. 6 months of the operation. This is the CT screen. 6 months of the operation. This is the photo of the operation.
换一个，观众了。
We can see ankle joint
啊，这
motion.
脚不是想疼吗？行人走路。
就后面的紧这儿，紧沿着或者这个位置是。
来，动，哎，换一个。啊，走。 好，好，好，过来。好。
Course of operation 6 months. The case 6. The patient was a 66 years old man who was hospitalized due to the good external necrosis of the Talus. Talus is broken and very small Talus. This is the MI. So we select a smaller Talus. Two weeks of the operation. 3 months of the operation. 6 months after the operation.
是吃人豆腐的。
那没什么问题，来脚脖子动一动。对，我们看看这是一个痛风性的关节炎，走路疼痛，活动受限，进行了一个全局部的置换。置换以后呢，
是吃人豆腐。
走，用手机拍过去走路路线是吧？来，转过来，转过来。手术前走不了是吧？走。
This is the case 5 and case 6.
来，老你哥俩，这是一个啊，回来，两个双举啊，两个人坐在一个都是右脚。好，踮脚，原来是痛风性关节炎，踮脚第一个换对了，转过去，右脚转过去的，术后半年，来，你俩活动。好，走。 对，好，对，这两个都活得非常好的效果。看他脚这疼吧？看看。
We can see they have a good work. The case 7, the patient was a 41 years old man who was hospitalized due to the autosomal necrosis of the Talus. This is the CT scan and X-ray. We can see MRI. This X-ray after the operation. 2 weeks after the operation. 3 months after the operation. 6 months after the operation. Now, experience and the insight. Patient was Talus fracture and the tibia talar arteries after the experience significant Talus calipers and the surrounding subtalar tissues contracture, which reduces the gap between the tibia and the calcaneus, and require the small processes of the surgery. The patient may experience symptoms such as the limit ankle joint movement and pain. For pain with no significant degeneration of the tibial joint and the only static degenerations of the Talus, their recovery would show a better improvement in the motion range and the pain relief of the Talus replacement surgery. Compare with patient of the Talar fracture and the tibia-talar arteries. This is our experience. Some men think they think related such has been demonstrated the TTR kind of alternative treatment operation can be combined tolerable, but such research still needs to be done to assess a patient, matching the implants of patient material of the articulation against the articular cartilage, and being longer-term outcomes for recognition must be given the TTR as the primary treat a patient for treatment of the several ankle joint arthritis. Vascular necrosis, osteochondrosis, and the infection-borne disease yet may be no prolong the inevitable fracture ankle, osteoporosis, and the osteodesis. Thanks for your attention.
Third speaker is Canjun Zeng. He comes from the third affiliate hospital of the South Medical University.
Hello everyone, this is Zeng Canjun from the third affiliated hospital of Southern Medical University, Guangzhou, China. My topic is clinical application of a 3D printed custom-made cementless prosthesis for tailor body replacement. Actually, I have performed lots of total tailor replacement and achieved promising outcomes. However, my topic today is partial tailor replacement or tailor body replacement. I have performed 2 cases, and let's see. Case 1 is a 32-year-old female who suffered from a car accident. You can find femoral shaft fracture, ankle fracture, Lisfranc injury, and open injury of the ankle. Most importantly, tailor body defect or tailor body loss. The tailor body could be not found anywhere at the site of accident. I did open reduction internal fixation of Lisfranc injury and close reduction internal fixation of the femoral shaft fracture. And I put an external fixator to maintain the alignment of the ankle and maintain the space of the ankle. My strategy in this case was span, scan, and plan. So the key problem lies on how do you deal with this tailor body loss? Would you remove the relatively normal tailor head? Would you choose ankle fusion or ankle replacement with relatively normal distal tibia? So my choice is partial tailor replacement. I performed CT scan of both ankles and I used Mimic software to mirror in filling the left ankle. And based on these images, I designed and produced a prosthesis. The prosthesis main body is made of cobalt, chromium, molybdenum alloy. This alloy has very good biocompatibility. And the interspace between the main body of the prosthesis and tailor head was made of titanium alloy with a porous structure. The porous structure can allow bone ingrowth, which can provide secondary stability. And the initial stability was provided by 2 rods at the interspace. I use anterior approach and I perform debridement and osteotomy using an osteotomy guide. And finally, I implanted the prosthesis into the ankle. These are pre-operative and post-operative X-ray images, which showed well positioning of the ankle of the partial tailor prosthesis. At 2 months after operation, you can find the dorsiflexion and plantar flexion of the left ankle was acceptable, and the positioning of the prosthesis is good. At 4 months post-operation, from the video, you can see nearly normal gait of the patient. However, if you watch carefully, you can find slightly varus of the left ankle. The positioning at this time is still okay. Unfortunately, the patient suffered from a second car accident and lost her life, so no more follow-up. Let's see case 2. Case 2 is a 15-year-old male. Again, car accident. Again, femoral shock fracture and ankle fracture and talar body loss. The talar body could not be found anywhere. And again, I designed a partial talar prosthesis. The main body of the prosthesis is still made of chromium alloy with good biocompatibility. And the interspace between the main body of the prosthesis and talar head is made of titanium alloy with a porous structure to provide secondary stability. And this is a cementless prosthesis. Now I designed 2 holes for the introduction of sutures. This can allow me to do suture augmentation, which I'll show you later. And I chose anterior approach, and I performed osteotomy using the osteotomy guide. And I implanted the implant into the ankle. And finally, I performed suture augmentation using the 2 holes prepared in the implant. Especially in this case, I found that the talar head was totally free. So I took it out and assembled it outside and put it in. This was at risk of talar head necrosis, right? Because of compromised talar body blood supply. And post-operative X-ray images showed good positioning of the talar prosthesis. And 2 months after operation, the positioning of the prosthesis was still okay. At 5 months after operation, you can see the dorsiflexion, plantar flexion of the left ankle was acceptable. However, with slightly stiffness. The stiffness can be partially explained by compromised post-operative rehabilitation. And from the images, you can find some evidence of talar navicular joint degradation and some degree of talar head necrosis, but the positioning is still acceptable. At 5 months after operation, from the video, you can see nearly normal gait of the patient, and the patient can go upstairs and downstairs freely. So let's make a summary. The partial replacement of the talars can preserve normal bone as much as possible. And the 3D printing technology facilitates custom-made prostheses. I designed porous structure at the interspace between the main body of the prosthesis and the talar head, which allows bone ingrowth and provide secondary stability. And the initial stability is provided by 2 rods. And furthermore, I designed 2 holes for the introduction of sutures. This allows suture augmentation and provided more stability. Regretfully, in case 2, at 1 year after operation, from the weight-bearing lateral view of the left ankle and foot, you can find the collapse, obvious collapse of the prosthesis and degradation of the talar navicular joint and necrosis of the talar head. At 2 years after operation, more severe. And at 3 years after operation, more and more severe. The patient felt severe pain located in his left ankle. And finally, I did fusion. So how do you explain the talar head necrosis? How do you explain the long-term failure of the partial talar prosthesis? This may lead us to believe that total talus replacement may be a better choice for this patient, right? However, I have stated previously that in case 2, during operation, I found that the talar head was totally free, with compromised blood supply. This may partially explain the talar head necrosis at long term. I still believe that partial talar replacement using the custom-made prosthesis will be a good choice for the patients with talar body loss, with nearly normal distal tibia and nearly normal talar head. If the talar head is full of blood supply, and the results may be better in the future. However, more cases should be done to prove these sorts. I would thank everyone for attention. Thank you.
Then it's my time. Good day, everyone. My name is Xu Tao. I come from Southwest Hospital, Army Medical University, Chongqing, China. My topic is about colorful printing of the total talus prosthesis from clinical application to fundamental consideration. All others declare that we do not have any commercial or associative interest and represents a conflict of interest in connecting with this work. As we discussed in this section, the 3D printing is a technology based on three-dimensional mold data using powder metal, plastic, or other adhesive material to manufacture products with metal level structure or complex geometry. It is widely applied in medicine such as bone and cartilage or 3D talars. There is a lot of technology process and basic materials. We will choose some of in this 3D printing. All 3D printing processes was provided by the funding from the China National Key Research and Development Program. This study was performed in line with the principle of the Declaration of Helsinki. Approval was granted by the Ethic Committee of the first affiliated with hospital of the Army Medical University. Let's get started from some cases. The case 1 is a 7-year-old male. He got a talus fracture and oral at 4 years ago. He feels ankle pain with ankle joint motion limited for 3 years. And the diagnosis is right talus collapse and necrosis as subtalar arthritis. So we performed the 3D printing talar replacement with subtalar and talar navicular fusion on the July 4th, 2016. This is our first case. We can see that before the surgery, the motion is limited. And after the 6 years, the patient feels good and without any complaint. This prosthesis was designed by 2 parts, was fixed with subtalar joint and talonavicular joint by 2 screws. The upper part is printing with cucuramo align as an affixation material. It gives a higher strength and wear-resistant accretions resistance. The lower part is printed like Talar as a structure material. It was printed with micropole to increase the surface roughness and to promote the bone ingrowth. There are two screws channels. The high processor dovetails slot was complete after assembly. The second case is 22 years old female. She felt pain in the left hand, the ankle for half a year, and the diagnosis is giant cell tumor of the left talar. We performed the 3D printing talar replacement with a subtalar fusion on the October 19, 2019. In this case, it was designed by one part, was fixed with a two joint by two screw. And the material is a cucurmol align. The tibia side is mirrored polished, and the subtalar joint are printed with micropole. And there still have the two screws channel. The third case is a 44 years old male. He got the left talar fracture and ankle dislocation, and Orof was performing on the hospital, and the diagnosis is left talar non-union necrosis. We performed the 3D talar without any fixation. We can see this. The patient is aligned with a varus, and after 3 years, he feels very good, and the outline is correct. This case was designed by one part without through hole, and the material is a cucurmol align. Artificial is mirrored polished. Before the fundamentals researches, we should build a financial element mold. The average measured ICC coefficient between the financial element mold and experimental data shows excellent consistency, which provides a validity of the three portions of the mold. The B is our result, A is the result from the edit. After obtaining a legible mold, the size data which come from the contralateral collapse talar could affect the outcomes. Therefore, we designed 4 different size talars, increased by 1.5% or 3% along the coronal of the vertical axis. The maximum stress on the tibia side are located at Talus nodal, and the prosthesis enhances stress concentrated of the medius malleolus side of the tibia. And obviously, increasing the prosthesis size enhances stability of the ankle joint, but in this case, it's joint extensive, so some patient feels uncomfortable. A really suitable size or slightly smaller size of prosthesis is better choice. However, the too small size of the prosthesis could lead to disability, especially in the joint. From main swing to the terminal swing, the loading is appropriated to be the relative status. The stratitudinal joint circle is stimulated by applying a loads of the different size and direction. And the fixation with the different methods was constructed and analyzed. The distribution of the pressure diagrams for the 3 different times the face of the mold is present. We got some outcomes. The micro moment between the joint was reduced by screw fixation. Without fixation, the displacement was reduced, and probably because the corresponding ligament supporting the connection was lost. But there was no significant increase in subtalar joint or talar navicular joint motion. For tibia talar joint, the pressure significant increase in the 3 phases. Without fixation, the present in the main stand and push-off physics tend to increase. And the motion region of the ankle joint are limited, which are consistent with the characteristic of the fusion surgery. Without fixation, the motion rates were limited either. So only in phase from the initial swing to the middle swing, the prosthesis may fall out. We get it because the gap between the anterior edge of the tibia and the dorsal edge of the navicular is widest. Meanwhile, the push force from the posted ankle joint could cause dislocation of the prosthesis. Another thing we care about is the materials. As we all know, the PEEK is a high-performance semi-crystalline material that has physical properties such as high resilience and strength. Due to the biology inertness, the PEEK material started to enhance its osteogenesis differentiation characteristic to improve the growth of the PEEK talus prosthesis. We have built one, but it was not performed with human being right now. And the third thing is coating. The hard coating could be applied onto the microstructure mold to influence wear, form filling, and demolding behavior in the microinjections molding. The tin coat has positive effects on the biocompetitive and the tribology properties of the implant surfaces. The advantages include the reduced the friction, the coefficient, and the wear rate of alloy substrate, which can significantly prolong the surface life of the joint prosthesis. Arc iron plating can be used to prepare high-performance tin protections coating material to the decrease failure of the tin's coat. Another coat is DLC film. It is a kind of testables amorphous materials containing diamond structure and graphic structure. The advantage includes high hardness, low friction coefficient, and good chemical initiate, and biocompetitive and multi-environmental adaptability. The PVD hard coating was fabricated submicron structure directly into the coating for the subsequent replication by molding. Then we got 6 different kinds of prosthesis. The crooked mold with the solid structure is the most heavy, at 160 grams, and the PEEK material is only 1/4 of the crooked mold prosthesis. So the design of power structure within the prosthesis aimed at ensuring that an overall performance meeting design requirement while minimizing the overall weight of the joint. Another thing is about integration of soft tissue and prosthesis. All ligaments and capsule on the talus was cut, including delta ligament, intraosteal ligament, and TFL or PTFL. Without soft tissue reconstruction, how to the prosthesis gain the stability is a question. It has soft tissue in growth, and prosthesis could be the keys in suit. We found that the power structure with 500 micrometers apertures triple periodic minimal surfaces was designed for the tend in growth, better collagen remodeling, and higher mechanical strength. And other things is like composite material was Europeans hydrogel in porous titanium reinforced integral of the soft tissue and the metal implant, or the compositives, the materials Cooper has antibacterial properties. Get a conclusion. Each material has advantage and disadvantage. 3D printing Talus prosthesis could be better designed and personalized, and more researches should be designed in the future, and more cases should be performed in the future.
All right. Well, thank you, everyone. We're going to wrap up this hour. You can join us on the next link next hour, and we'll see you at 1 o'clock.